Welcome everybody to our next SMGR Briefs. Hope you're having a good Friday. We'll have a good weekend in anticipation of that. I'm saying it now, but we have a returning guest, Dr. Gary Green. You all know from infectious disease, we're bringing it back for his usual topic because it's that time of year, both in terms of clinical disease and vaccination time. So we asked Gary to come back to talk about RSV, COVID, and the flu, because we're already seeing articles in the newspaper talking about the triple demic, and Gary's been quoted in the newspaper several times already, so it's very timely. So what order do you want to go, Gary?
So first of all, thanks for having me. It's good to see everyone again. So thanks for being here. Thank you for letting us back on your iPhones. I want to talk about RSV first because it's in the news a lot, and there's been a lot of operational work around RSV. And we're going to do a little bit of a primer on it, similar to what I sent out on an email, but a little bit more extensive, so you have a better understanding of why we're doing what we're doing it. Okay. So the big why. And then we'll talk about COVID vaccine, and then we'll talk about flu vaccine in the very end. So the first slide is kind of what we're gonna present. So that's going to be the outline for today. It'll take a little bit longer. We try to do this at 5 to 7 minutes. This may go over a little bit, maybe 10 to 15 minutes, just to update you a little bit more on what RSV is all about and why in adults. So the first slide I'm going to show you is an electron micrograph of RSV. I actually sent this out in the email I sent, and to the right of that is actually a cartoon of RSV, and I highlighted the fusion protein. The fusion protein is very important for RSV. Now, RSV is a respiratory virus, and it's in the class of Paramyxoviridae. That's important because that's not influenza. That's not COVID. That's not a coronavirus. It is a metapneumovirus, a parainfluenza virus, and a measles virus. The RNA in RSV is a little bit more conserved, which means it doesn't mutate as rapidly. So you don't chase this like you chase all these subvariants of coronavirus. You don't chase this like we chase every year what the circulating influenza virus is. So it's a more conserved RNA virus. It is transmitted by droplet, and it's also on fomites. So it can survive on table surfaces, for example, or kids' toys for 30 hours. So RSV can last a long time, so kids can pass it with toys and doorknobs, as well as with coughing and sneezing. So respiratory syncytial virus has always been thought about as a pediatric virus. And you and I talked about it last year because we talked about the growing mortality and the epidemiology of RSV in the elderly. ID docs have known about this for a while because some viruses cause lower respiratory infection. Flu is a big one. Coronaviruses typically did not cause lower respiratory infection. They were just a head cold, kind of like what I have right now. But the new strain, this pandemic strain of coronavirus, SARS-CoV-2, did attach to our alveolar cells, causing you pneumonia and a lower respiratory illness. RSV is different. RSV doesn't really attach as much in the alveoli. It attaches in the very terminal bronchioles, especially in adults. So when the elderly get RSV, it's typically a wheezing illness. It's not as much a pneumonia. The X-ray may be normal, but they're wheezing very much. And if they're frail and elderly, they develop hypoxia from this terminal bronchiolitis. So RSV is a little bit different, but it is a respiratory virus in the lower tract. And your question the last year was, how come we're seeing it? How come it's on the news right now? And one of the reasons is we're better at diagnosing it. Yeah, now that we have RT-PCR, we can actually diagnose respiratory syncytial virus much better than we did before with like immunofluorescence stains. So the next slide is a little bit on the epidemiology of it. It's a winter virus. It's a winter virus that typically is between October and April, and it peaks at different times. Typically, RSV predates influenza. So typically we see a rise of RSV in children before we see the influenza season. And we're seeing that right now because RSV is starting, especially in Florida and in Georgia. There have already been cases above that 3% epidemic level. It's the leading cause of hospitalization for children in the US, especially infants. 1 to 3% of kids under 12 months of age, 1 year of age, get hospitalized every year for RSV. 1 to 2 million clinic visits every year for RSV in pediatric offices. In kids under 5, and 50 to 80,000 hospitalizations for kids. But kids do much better. It's about 100 to 300 deaths a year in the United States, as opposed to influenza data. So kids get hospitalized more than adults, but they seem to survive it better. Now, probably the worst RSV infection you're going to have in your life is going to be under the age of 2. The first time you get it, it's the most severe immunologically as well as phenotypically. Now, when adults get RSV, it's very common over the age of 65, often manifests, as I said, as bronchiolitis, terminal bronchiolitis, and notice wheezing is a key feature in the elderly. about 160,000 hospitalizations every year in the USA. So it really mirrors influenza. So if someone comes in and they have a lot of respiratory distress and the flu test is do it again and it's still negative, it might be RSV. The good thing is now we're doing in the hospital influenza A, influenza B, and RSV, RT-PCR. So our test in the hospital in the ER for admission, our PCR test, so we'll be able to pick it up. 6,000 to 10,000 deaths in the year in the United States in the elderly. So it has a higher mortality in the elderly, and that's something that we are just appreciating more. One of the reasons is last year was such a bad year, and I'm going to show some of that. The next slide just shows the pediatric epidemiology. Now, our pediatricians here, they know this really well, that under the age of 2 is a real risk factor. Under the age of 1, it's a higher risk factor, but you really worry about kids in the first 3 months of age. So that's not news to our pediatricians. I think this slide is very telltale. The next slide shows California Department of Public Health data. And this just shows last year. Every column here represents the spread of RSV deaths in California by year. And so each of the columns is a season. The purple that you see are the deaths in people over 65. So again, children get much more infection with RSV. They get hospitalized more, but it's the elderly that get it over 65 that die of it. And last year was a banger year. Over 250 deaths in California. 83% of those deaths were in those over 65. And that's why this year the vaccine is being targeted for the elderly. Now the next slide is very telltale. This is an epi slide from CDPH, and it shows in the dark blue, that was last year's season. There's 2 things to know about last year's season versus the other seasons here. Last year's season came early. It probably came early because everything has been thrown off with the pandemic. Things just aren't the same in the pandemic seasonality with a lot of respiratory viruses, including RSV. And you'll see that RSV, this is a death mortality slide. You can see how high the mortality went for RSV, and it lasted for a really long time. It just didn't peak over a couple weeks. Now that got the attention of everyone, because last year we were talking about this triple pandemic. And this year, I do not think there's going to be a triple pandemic, because I think things are going to hit different times. A triple pandemic is when they all hit at the same time. But I think we're going to see RSV first, we're going to see flu next, and who knows what's going to happen with the new COVID-19 epidemiology. That's going to be across the board. But you have a question about this?
No, I don't have a question. I think this slide, which shows you the high intensity last year, is what got pharmaceutical companies interested.
Oh, I think you're absolutely right.
They saw an opportunity there, both on an economic and a human treatment level, to do something about it. So they have come through.
I think you're absolutely right. Now, you might want to say, oh my gosh, we just developed a vaccine very quick. We've known about RSV since 1959. We've been doing vaccines back from the polio days of RSV. But the vaccines were either not very effective or not very safe. It is just simply a coincidence that we had this banger year and the vaccine breakthrough happened last year. Because the vaccine studies were starting the year before this. So the vaccine studies started the year before this. That's why now we have 2 years of vaccine efficacy research. That data is appropriate. So you're right, last year was a banger year. Now this year in Australia, they had an early RSV season and it was severe. So we might see another early season this year, and we may or may not see a severe year. We don't know about that. So that's the most important thing. What you guys want to know is what's going on with the new vaccines. 2 RSV vaccines have been approved by the FDA, and just this week, the ACIP committee from the CDC has made recommendations on them. Now there are 3 vaccines in the work. Moderna's making an mRNA vaccine, but these vaccines are actually protein vaccines. So this is for Gigi. Gigi asked me, can I know a little bit more about the vaccines? So I've done a little bit more information here for Gigi. They're a recombinant vaccine. They're a protein subunit vaccine, kind of like we do for hepatitis B. And the specific protein targeted is this fusion glycopeptide protein that I showed you early on in the cartoon. There's an attachment protein and there's a fusion protein. If you attack the fusion protein, you don't allow complete attachment with the virus. And so there are 2 vaccines available. We think they're going to be given every 2 years, not every year. Why is that? Because a study that started 2 and 3 years ago on the vaccine showed us that immunity will last for 2 years, but if you give another booster the following year, it doesn't do any benefit. So there's no benefit to annual vaccination. Now this vaccine in the elderly is covered by Medicare Part D. It's going to be very similar to shingles virus. The shingles vaccine, Shingrix. But it's important that you tell your patients that they may have to pay for this up front, and then they may have to get reimbursement from the pharmacy. So this one you can get at Costco, Rite Aid, CVS,
Yeah.
but it might be a little bit different, and the cost is about $300 for
Okay.
this vaccine this year.
Okay.
So the two vaccines available right now are a Pfizer vaccine called RSV Pre-F or Abrysvo. Abrysvo is, again, a recombinant protein subunit vaccine. Its efficacy is 89% efficacy in the first year. It drops to 56% at year 2. And it's that effective in preventing long-term respiratory disease. So that's two or more symptoms of cough, wheezing, shortness of breath, chest pain in an adult. Now the Pfizer vaccine, the Abrysvo vaccine, is the only one approved in pregnancy. And it's approved in pregnancy at 32 to 36 weeks. The other vaccine, which is made by GlaxoSmithKline, that's called Arexvy. Arexvy is it's a recombinant protein subunit vaccine, but it has an adjuvant in it. And it's the same adjuvant used in Shingrix is used in this vaccine, which means it's kind of a thumper. So you may get more of a side effect of local reaction with the Arexvy vaccine. Its efficacy is pretty good, 88%. I mean, if you can give that kind of data, 88, 89% for both vaccines, 78%, this one holds it better in the second year, probably because it's adjuvanted. Now, the studies were meant to, and I guess all the data hasn't been finalized, did they prevent hospitalization, did they prevent death? It wasn't quantified in the studies. So it very likely will, just like the influenza vaccine, with this kind of high vaccine efficacy. If you could prevent lower respiratory tract infections, you're gonna prevent hospitalization and death, but the data isn't there quite yet. The safety features in one study of 38,000 patients, 20 patients developed AFib. Is that true, unrelated? We don't know yet if that's cause and effect. 6 patients out of almost 40,000 had neurologic events, including encephalitis and Guillain-Barré. Again, we don't know if that's a signal of the vaccine or just background noise. So I'm going to give you 2 RSV records. What does the CDC say? On the next slide, the CDC says, adults over the age of 60 with comorbidities, there should be shared decision-making with their provider. And from my point of view, the CDC says that a lot, and it's a little bit annoying. Because as a provider, look, I just want to know, what do I tell my patients, right? Do they get it? Do they not get it? And is this the way the CDC just doesn't share the burden of recommendations? And the shared decision-making is based on heart disease, lung disease, renal disease, liver disease, diabetes, and immune suppression, or chronic neurologic disease, like someone with MS. So here's what I think. Anyone over 75, just give the vaccine, recommend it. Because you never know, over 75, people are likely to have more than one comorbidity. If you have a 75-year-old person who has no medical problems, is running marathons, is going to the Olympic trials, God love them, maybe that patient doesn't need it. But I think over the age of 75, most of our patients can benefit from it. Anyone over 60 who is frail or in a long-term care facility. So think about that. The frail are really important for RSV pneumonia and RSV death. And then the other one is adults over 60 with comorbidities. Those are the comorbidities that you can talk to them about. So I have a lot of patients in my clinic who have bronchiectasis. I see them with bronchiectasis and secondary pneumonia and bronchitis flares. All of those patients, I'm going to recommend this vaccine over 60. If they're 60, 61, 62, I have a couple patients that maintain a high activity, they're riding a bike for good pulmonary rehab, I'm still going to recommend the vaccine to them because I think it's going to be very important. But we're not going to have the vaccine. So very likely we're not going to have much of this vaccine at all in the clinics. It's going to be really positioned in the pharmacies because of this Medicare Part D thing.
Okay, so that's getting down to the nitty-gritty of what these people want to know. We understand who should get the vaccine, but the mechanism is likely that you're going to send them to the pharmacy.
Right. So
60 and over.
I think we're going to earmark a little bit of vaccine for pregnant patients. So we may earmark that and work closely with OBGYN in that population. But for our patients who are 60 and older, very likely I would recommend going to the pharmacy and get it. Here's the other reason, and I didn't put this in a slide, but it's actually just as important. You cannot give all 3 vaccines the same time this year. You want to give RSV vaccine 2 weeks before or 2 weeks after you get a flu and COVID shot. So the new updated COVID vaccine and the new flu vaccine this year, you can give those together, but you want to separate the RSV vaccine by 2 weeks. So again, tell your patients go to the pharmacy. Now would be a good time. It's available in the pharmacies now. And then when we're up to date and we're ready for flu and COVID vaccination, 2 weeks from now, it'll be a perfect time.
Okay. Good.
Questions about that? Because we talked a little bit about RSV last time. What are your thoughts about that? I mean, you've done medicine, for more season than I am.
Wow. Yeah.
And
I think it's great. I think it'd be useful when it's available for kids. Seems like it's most useful. I think it's gonna be a challenging year to get people to take vaccines.
I think so too.
I do.
When they go to the pharmacy and they have to kick out 300 first and then wait for 3 months for the paperwork for Medicare Part D,
Yeah.
that's going to be a barrier.
So we'll see.
So this next slide is for Gigi. I made this slide specifically for you, Gigi. So this shows you on the RSV virus, there is a little arrow there to the RSV fusion glycoprotein. If you take that glycoprotein and specifically look at two areas and make that a recombinant structure, put it into a vaccine, give it to someone, have their immune system respond, then you develop these neutralizing antibodies. And typically the IgG neutralizing antibodies are most important. Then when someone gets infected with RSV, the neutralizing antibodies in the system glob on to the fusion protein and it doesn't allow the virus to attach. So this is kind of the immunology behind it. I didn't put in the antigen presenting cells and the CD4 cells that give it to the memory cells, but this is a good schematic on how does this work when you talk to your patients about it. What about kids in RSV? So RSV vaccine is 60 and older. What about children? We don't have an RSV vaccine for kids. Now you could vaccinate a pregnant woman and she'll have antibodies and passive immunity for the child, which will offer a benefit. But this year, new on the scene is a monoclonal antibody called nirsevimab. And this is a new monoclonal antibody that's probably going to replace the older monoclonal antibody for high-risk kids. Our pediatricians have known a lot about this. I've been on a SHVAC call, a Center Health Vaccine Advisory Committee. Brian Pertowski's been on that call as well. And so we'll make sure that our pediatricians are up to speed on this. But in high-risk infants, and maybe even healthy infants, born today, they'll get a single dose of this at birth. So as soon as they're born, before they leave the hospital, that's kind of how we're going to position it at our hospital. They'll get this single dose, and that'll protect them during the RSV season, once the season starts. So we're waiting for the CDC to come out with specific guidelines on this, but and we're waiting for like the American Academy of Family Practice, IDSA, to give their guidelines. But this year, with RSV starting, we're very likely going to start this. And it's cost effective. You know, it's like $450 a dose for a single dose, where if you're doing the old monoclonal antibody, palivizumab, that one is 5 doses every month at $17,000. You know, and that was really dedicated for high-risk kids, like preterm kids, kids born with congenital heart defects. This one may be positioned even for healthy kids, because even healthy kids in that first 2 years don't survive RSV, and it's a tragedy for families.
So more to this.
Yes, more to
But
come.
you anticipate it might become like hepatitis B, given to newborns in the hospital.
That's right, and we know it's safe with vaccination as well. So this would be the new thing your kid gets out of the hospital. Yeah.
Okay, well, let's switch gears back to our old favorite, COVID. And we've talked about high COVID positivity in testing, and then all of a sudden it sputtered. So this is an interesting slide.
Yeah, so you and I were talking about this before. I'm gonna let you talk about this. What do you think about this FE slide?
So I see it spiked right up there, and then it dropped way down quickly. And I'm wondering if this is a delayed reflection of going back to school.
I think you're right.
So, you know, about a month from now, going back a month is when we open the schools, indoor activity, everybody getting sick. So if I'm right, then we might see little spikes after Thanksgiving or after Christmas.
Right.
But still, our baseline's very high. We'll see how far it comes down.
Right, yeah, I think coming down is gonna be very important to know what's gonna happen again. It's definitely gonna go up. And I think you're right. I think there are 3 things that drive our COVID activity. One is when everyone starts going back to school, back to work, and not wearing masks. The other one is when it gets cold. When it gets cold quickly, if we have an early cold season, people come indoors, especially a rainy cold season. You know, people aren't going outside in the gym, you know. And then the third thing is just the holidays. As more people travel in the holidays, you start spreading all these subvariants of Omicron from one end of the country to the other.
Yeah.
So I think that's what's going to drive, and we're definitely going to see more. This spike is not over, and I think it was really with kids. So this is really interesting. I just got this today. So this came out of a CDC IDSA lecture from today. This is CDC data on right now who's going to the emergency department with COVID. And as you can see, it's all age groups. And all age groups are going to the ED right now because there's an uptake in activity and there's an uptake of hospitalizations for COVID. It's not a big uptick, but it's a moderate uptick. And it's all age groups. It's not just the elderly. So this is important when people say, well, should I get the new COVID vaccine? I think you should. What age group should? Every age group is coming into the ER. So I think this offers protection. Last year, I think about 17% of people nationwide got the booster. Got the second booster. We're hoping for a better uptick. But this slide tells me What age group should get it? All age groups should get it. I think that's gonna be really important. So here's about the COVID vaccine. It's just a simple slide. There's a new COVID vaccine. It's an updated vaccine. That's the language from the CDC. So don't call it a booster. A booster means we used an old vaccine and gave it again. This is a new vaccine based on the XBB 1.5 subvariant of Omicron. And so far, the subvariants that have come out since this has been developed, we're developing neutralizing antibodies to cover the subvariants. So we don't see any escape subvariants coming out, even from this new updated vaccine. Who should get it? Single dose, everyone over the age of 5. Totally easy.
Yeah.
Right?
Yeah.
Single dose, everyone over the age of 5 can get this vaccine. Now, if you had a bad reaction to this vaccine, the Novavax vaccine is going to be coming out soon, but it hasn't received FDA approval yet.
That's a different formulation.
Yeah,
It's not an mRNA.
the Novavax vaccine is not an mRNA vaccine, it's a protein subunit vaccine. Now, what about under 5 years of age? Okay, that's different. So our pediatrician is going to know about this. Between 6 months and 4 years of age, if you've been previously vaccinated, you may get 1 or 2 doses of a COVID vaccine. It depends on what you got and when. If you've never been vaccinated between the ages of 6 months and 4 years of age, you'll get 2 doses of Moderna or 3 doses of Pfizer. And just so you know, we're going to be getting the Moderna doses.
Okay.
So Sutter has purchased Moderna. We're going to have it in the clinics. It's a single dose vaccine. You don't need that crazy time frame with freezing and can't move it but once or twice. It'll be just like getting a flu vaccine. We'll have it in the clinics, and you can give the COVID vaccine with the flu shot. You can do it in the same arm or in different arms, doesn't really matter.
So we anticipate having it in clinics, we don't have it yet. Is that
Correct.
accurate?
So commercially, we're going to be able to buy this vaccine on September 18th. It takes 3 days to ship it. So the very, very earliest we're going to see it anywhere is going to be on the 21st. So sometime after the 21st, probably within a week, we'll have this vaccine in the clinic. We already do have the flu vaccine. The flu vaccine just arrived this week.
Okay.
This will be coming soon after that. The other thing is that, what about myocarditis? Patients ask me this, would you give your kids this? Now I have an 18-year-old kid and a 21-year-old kid when the vaccines first came out for COVID. And I actually gave my 21-year-old son the vaccine as well as my daughter who's 18. Now they're a couple years older, I would still do it. Mm-hmm. The myocarditis that people got, the young, especially young males got with the vaccine, was about 20% lower than the rate of just myocarditis from the illness of COVID. Mm-hmm. And we see that in subsequent boosting doses of COVID, that the myocarditis rate is lower in subsequent doses than in the primary series. So the chance of myocarditis is rare, and it's more rare than if they got the primary series. So I think it's really safe. Getting myocarditis from the COVID illness is 5.6 times higher than the vaccine. So I think risk benefit rate, yeah. And then the last thing is, what about the flu? We haven't seen the flu yet, but I'll give you some data about what happened in Australia and in Latin America. Australia had a moderate influenza A year. It was H1N1. Latin America, Brazil, Peru, Paraguay, they also had an H1N1 year. So we're kind of positioning for an H1N year, which is it's a good thing. H3N2 is the other influenza A that's harder to match in the vaccine, and it's more of a thumper illness. So if we have an H1N1 year, that might be favorable. So far, there's no flu activity, very, very low flu activity. Like I said, we're seeing RSV in the southeast, Florida, Georgia. We're not seeing influenza yet, and typically, influenza trails behind RSV. So what are we doing this year for influenza? Vaccine's already in the clinic. We're doing quadrivalent vaccine. What does that mean? That means it's one strain influenza A, H3N2, the second strain of influenza A, H1N1, and 2 strains of influenza B. There seems to be a good match this year. It's okay to give these vaccines with an egg allergy. We knew that last year, but I'm just going to repeat that. And who gets this? Everyone aged 6 months and older should get the flu shot. High dose for anyone 65 and older. And the ACAP and the American College of OBGYN says the flu vaccine is safe in any trimester of pregnancy.
Okay. So we often give a lot of influenza vaccine in our clinics.
Correct.
And so the standard this year should be, you're here, let's give you a flu shot and a COVID shot.
Absolutely.
And just ask them to opt out if they want to, but just assume that they should get it.
That's the standard of care, and that's exactly how I'd approach it.
Okay.
Yeah. And not the RSV at the same time, but
Right.
they should get that in the pharmacy.
And again, the RSV for everybody is delivered at the pharmacy.
Yeah. So I'm sorry that was a lot of information, but I wanted to give some context and perspective on why we're doing what we're doing with all 3 viruses either circulating or about to circulate.
Okay, and likely we'll touch base again in a couple months.
Yeah.
We'll see how it goes.
Okay.
All right, thanks, Gary, very much.
Bye-bye.
Hope that was helpful. Thank you.